This is Ian Bodford.
And Liang Liu.
And welcome back to the Clinical Correlation.
Today's case is... This is a 30-year-old female with no previous diagnosis who has had chronic abdominal pain for several years. She presents with complaints of abdominal pain and rectal bleeding.
She tells you that she has never had rectal bleeding previously, and her abdominal pain is a cramping sensation, and it is worse than she has ever had.
On further questioning, the patient reveals that she was seen in the GI lab this morning, and she had a colonoscopy performed to investigate her chronic abdominal pain.
Here are her vitals on presentation. Slightly tachycardic, but otherwise unremarkable.
On exam, the patient appears comfortable, but is tender in her suprapubic region, with slight guarding. Rectal exam reveals bloody stool.
Workup shows a leukocytosis of 20, with possibly a drop in hemoglobin to 12.5. But in a female of childbearing age, it is hard to tell if this is her normal or a significant hemoglobin drop.
Here are her CT scans.
In case you missed it, let's just highlight a few items in the scans. You can see in the coronal view that there is free air near the rectum with what appears to be a metal object in contact with the wall of the rectum and surrounding inflammation.
Again, on the transverse view, free air is seen outside of the rectum and a metallic object, likely the clip, appears to be located at the site of the perforation through the wall of the rectum.
The patient was taken to the OR for surgical repair by colorectal surgery and recovered without any difficulties.
This is an uncommon yet not unexpected complication of colonoscopies.
Colonoscopies are a commonly performed procedure for diagnosis and treatment of a number of conditions and symptoms. It is also used for screening and surveillance of colorectal cancer.
Up to a third of patients reported at least one minor transient GI symptom after colonoscopy, but serious complications are uncommon. A number of systemic reviews have investigated the rate of complications, and the cited overall serious adverse event rate was 2 to 5 per 1,000 procedures.
More than 85% of serious complications were reported in patients undergoing colonoscopy with polypectomy, and studies have found a more than 7-fold increase in the risk of bleeding or perforation associated with polypectomy, which our patient underwent.
In examining the patient presenting after colonoscopy, it is important to get as much information as possible about the procedure.
Specifically, what anomalous findings were noted, duration of the procedure, the quality of the bowel preparation, pain associated with the study, the amount of analgesia required, whether prolonged abdominal pressures were required, whether biopsies or polypectomies were performed, and if so, how many, the location, the size, with what technique, and what hemostasis was used.
This all may help identify the exact injury.
So what complications can we see with colonoscopies?
The most common complications are perforation and hemorrhage.
Colonic perforation during colonoscopy can be the result of mechanical forces used against the bowel wall, barotrauma, or as a direct result of therapeutic procedures.
Patients can present directly from the endoscopy suite, but more often there is a delay of hours to days. They will complain of persistent abdominal pain and distension and can develop peritonitis. Objectively, patients have leukocytosis and fever, but up to 10% of patients are asymptomatic.
Upright plane radiographs of the chest and abdomen may demonstrate free air, but CT scans are superior for evaluation of perforation.
The rate of perforation reported in large studies is 0.1 to 0.3%. Generally, this is surgically managed, though depending on the damage, endoscopic management is also possible.
Hemorrhage occurs most often with polypectomy, though it can occur during diagnostic colonoscopy. With polypectomy, hemorrhage may occur immediately or can be delayed for several weeks after the procedure.
The incidence of hemorrhage is 0.1 to 0.6%. Repeat colonoscopy may localize the source of bleeding, and red blood cell scanning may be needed to identify an ongoing source of bleeding. Angiography is a useful adjunct in both diagnosis and treatment.
Acute cardiopulmonary complications are associated with the agents used for sedation and anesthesia.
In addition to these complications, colonoscopies are associated with an increased incidence of cardiovascular events in the 30-day post-procedure period, with an event rate of 1.4 per 1,000.
Post-polypectomy electrocoagulation syndrome refers to the electrocoagulation injury to the bowel wall, which essentially is a transmural burn. This is exceedingly rare, and patients will present 1 to 5 days after colonoscopy with fever, localized abdominal pain, peritoneal signs, and leukocytosis. Management is conservative and includes IV fluids, broad-spectrum antibiotics, and NPO until their symptoms improve.
Infection after colonoscopy is possible as there is a transient bacteremia in approximately 4% of procedures, whether with or without polypectomy. While case reports do exist for infection after colonoscopy, there is no definitive causal link and no proven benefit of antibiotic prophylaxis.
Even more rare are explosive complications. I'm sorry, what?
That's right, explosive complications. A 2007 review reported 9 cases, each resulting in colonic perforation and in one case, death. Gas explosions can occur when combustible levels of hydrogen or methane gas are present in the colonic lumen, oxygen is present, and electrosurgical energy is used. Suspected risk factors include the use of certain types of preparations and incomplete colonic preparation prior to the procedure.
More likely, patients will complain of bloating 25% of the time and abdominal pain and or discomfort 5 to 11% of the time.
Other complications cited in the literature include splenic rupture, acute appendicitis, diverticulitis, subcutaneous emphysema, and tearing of the mesenteric vessels with intra-abdominal hemorrhage. Chemical colitis may occur if a certain disinfectant has not been adequately rinsed from the endoscope.
Overall, death is very rarely reported. A 2010 review of colonoscopy complications cites 128 deaths reported among more than 300,000 colonoscopies, for an unweighted pooled death rate of 0.03%.
Some of the studies reported all-cause mortality, while others reported colonoscopy-specific mortality within 30 days of the colonoscopy. Among those reporting all-cause mortality, the rate was 0.07%, while among those reporting colonoscopy-specific mortality, the rate was 0.007%.
To summarize, colonoscopy complications and mortalities are exceedingly rare.
That said, get a good history and take your patient's abdominal pain and rectal bleeding seriously, as perforations and hemorrhage are the most common complications to consider.
Be sure to ask what exactly was the indication for the colonoscopy and what was done, as this can clue you into possible complications.
If there is any doubt, get a CT to evaluate. So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotified.
And me @EMLLou.
Thanks for listening.